I don't forget. And well, today this encounter is gonna be more like an introductory encounter. We are gonna be explaining some basic concepts that belong to pathophysiology and how we relate the physiology with the pathophysiology and how we are gonna use it in the future, why it's important to understand very well the pathophysiology of diseases. We're gonna also going over the syllabus and explain a little bit how we have planned this semester. Okay, so you have an understanding of the big map of the course. Let me start sharing some documents here. Let me start sharing the syllabus. You already have it on the Blackboard. Okay, so this is what you have on Blackboard. I also put a document there that is like a schedule of with the plan, the idea that I have in mind. Okay, this is something that I created and I consulted, okay, with Dr. Diaz, and she told me that it was okay, but we have the experience from the past semester that sometimes the schedule changes and we have to do modifications. That's why I'm going to explain you what I did there so we don't have any surprises. Okay, there you have information. This is more or less exactly the same thing that you have in every syllabus. And you can, when you navigate this, if you want to use the syllabus to have an idea of the most important things, I recommend you to use this view, okay, in which you can see this navigation with the most important things that belong to pathophysiology. You have here the different topics, introduction, then we are going to move to a brief inflammation and inflammatory response that is very important to understand later the pathophysiology of the skin and dermatologic disorders. Then we are going to move to the eye, ear, nose, and throat, lung disease, and cardiovascular disease. Okay, in every section, you're going to have the learning outcomes and the learning objectives. So remember, these instructional objectives are the topics that we are going to be using to create the exams. Okay, this doesn't mean that this is all the topics of the ENT or pulmonology, etc., but are the most representative of diseases of the different organs. Now, besides having the instructional objectives, we added the learning outcomes. Okay, what is this for? Okay, when you study, what are you going to do with these things? For example, let's move to these instructional objectives. Okay, in the instructional objectives, you have the diseases that we are going to be covering. For example, in the case of pulmonary disease, we are going to be speaking about COPD, asthma, different other diseases that produce a, a restrictive lung disease. We are going to be talking about pulmonary edema, embolism, pulmonary hypertension, pneumonia, etc. These are the diseases, okay? And about every disease, we are going to be talking about the etiology, about some relevant risk factors, epidemiologic details, complications, different manifestations, signs, symptoms, and what could be the potential complications. Notice that in pathophysiology, we don't cover, at least not in much detail, the aspects of diagnosis and management. However, okay, in order to understand why we select some diagnostic tests and how to interpret diagnostic tests and what to do with the patient, how to manage the patient, it is essential to know what the disease is about, what causes it, what is the natural progression of the disease, what could be the complications, and how the same disease may manifest differently depending on the type of patient. For example, a pneumonia is not the same pneumonia in a young, healthy person. Let's say someone in the military that gets a pneumonia because of the living conditions Okay, it's not going to manifest the same, and it's not going to have the same prognosis that the same pneumonia in a person who is 85-year-old and maybe has diabetes, hypertension, and some other comorbidities. So we are going to study the differences, okay, between these diseases that appear in the instructional objectives, and we are going to be testing them by using these learning outcomes. These learning outcomes is what you are supposed to get after you finish the course. Okay, so for example, we can create a question that gives you a clinical vignette, okay, that has any disruption, okay, any problem in the lungs or the respiratory system in general, and the student has to identify what is the cause of that disruption. Okay, let's say someone has an abscess, or someone has a tumor, or someone has an infection. Okay, given this brief vignette, okay, the students need to select in these multiple choice questions what is the most likely etiology, okay, for that dysfunction. Okay, also you can have a clinical scenario exactly the same with pulmonary disease in this case, and the students simply have to select the most likely diagnosis. This is a very classic question in medicine. Then there could be other type of questions that, for example, we give you a vignette, okay, and we don't ask you for the diagnosis. You have to analyze by reading the vignette what is the most likely diagnosis, then to select among the given choices which is the risk factor. For example, let's say we give a vignette with a pneumonia. Patient that comes with a fever, chills, a sputum that is rusty in color. The patient has pleuritic pain. And well, in your mind, okay, this is a pneumonia. Now, the question is not gonna say what is the most likely diagnosis, what is the most likely etiology, or which of the following microorganisms, okay, or other question related to the pathogenesis. Okay, we are going to be later explaining what is the difference between etiology, pathogenesis, etc. Now, notice that then we have another type of question, okay, that is probably a little bit more complex, okay, and here instead of asking what is the diagnosis or what is the etiology or what is the pathogenesis, we may give you, imagine you have in your mind, okay, this is a pneumonia, and the etiology is Streptococcus pneumonia, and it's an infectious disease. So we give you some other diseases, okay, without including pneumonia, and ask you which of the following conditions share or have a similar pathogenesis, okay, or uh, like the disease that we are talking about here. So maybe in the list we give you myocardial infarction or nephrotic syndrome, renal failure, and another infectious condition, meningitis. Well, of this list, meningitis is the only one that may be produced by this bacteria and has also an infectious nature. Okay, other type of question. Okay, after you have your diagnosis in mind, okay, pneumonia, to keep the same patient or the same disease, okay, identify other signs and symptoms, physical exam findings, or diagnostic test abnormalities. So let's say we give you the pneumonia, the patient has fever, chills, cough, sputum, etc. Which of the following do you expect to find in a chest X-ray, or which additional finding do you expect to find in this patient? And we can give you, for example, a consolidation in a chest X-ray, or I don't know, other things that have nothing to do with pneumonia. So select what else you expect to find. And then based on the diagnosis, okay, identify modifiable risk factors or other condition that could be a point of intervention. Let's say smoking for the case of pneumonia, or living in crowded conditions, or different things. Okay, these learning outcomes are very important that you analyze them because these are the different types of questions that you may have in your exams. Okay, and then what? Based on this diagnosis that you have in mind, okay, recognize the pathogenic pathway linking the etiology with the clinical findings. Okay, what is that? Let me show you one example. I was looking here at this beautiful website that I like a lot, that is the Calgary Guide, something that I recommend all the students to always look at because it's an amazing job made by students in this Calgary University in Canada. Okay, it's made by students, but it's supervised by professors. So maybe I think I've been using this for over 3 years now, and I have found only one tiny mistake one day. Everything else is amazingly well done. And I was looking at, for example, the example of schizophrenia. Okay, how do you look at these slides? For example, here you have the representation of schizophrenia, but they have tons of these for many, many other conditions. Okay, you have different colors. For example, in blue, they have all the etiology and pathophysiology. Okay, then in this little, I don't know what color is this, they have the mechanism, okay, that leads from the etiology to the different signs and symptoms. Okay, and in this case, they don't have represented the complications, but in many other conditions, this continues, and you have different complications. Okay, what could be complications of schizophrenia? Well, maybe they can attack someone, or they can commit suicide, or they can have a drug overdose, or they can have different other things. Okay, but this is not represented here. So let me show you one example of how this works. You study the disease, okay? In schizophrenia, for example, the patients normally have different manifestations, different signs and symptoms that we describe as positive or negative symptoms. What are the negative symptoms? Okay, or what is the difference between a positive and a negative symptom? Negative symptom is something that we normally have and lose. A positive symptom is gaining someone that we didn't have before. Okay, that the word positive doesn't mean that it's good. Okay, it's simply the gain of something. What are the negative symptoms in schizophrenia? Diminished expression, diminished affective affect, or affective flattening. Okay, problems with thinking, cognition. Okay, this diminution of thoughts, a lack of social interaction, this withdrawal, symptoms that were described in the past as autistic have nothing to do with what we know today as autism, but these were described as autistic symptoms many, many years ago. And what are the positive symptoms? Delusions, hallucinations, okay, disorganized speech, okay, the disorganized motor behavior. Now notice that the positive and negative symptoms are produced by different mechanisms. Okay, for example, the negative symptoms are produced by decreased dopamine in the in a pathway that goes to the brain cortex, and the positive ones are a result of increased dopamine in the limbic system. Okay, now why these people have these issues? Well, that's difficult to know. Okay, as scientists, we always have to recognize the limits of our knowledge, and there are many things that we don't know about many conditions. Okay, we know that there is a genetic predisposition, okay, and there is a hypothesis that is the predominant now, that is this disbalance in dopamine. Okay, there are other theories. For example, some genetic modifications, things that are explained here. Okay, so A question in pathophysiology may ask you, which is the etiology of schizophrenia? Well, imbalance in dopamine in some areas of the brain, plus a genetic predisposition. That is, to the best of our knowledge, that is the etiology of schizophrenia. Okay, now what is the mechanism? Well, there are abnormalities in the dopamine metabolism transmission in different areas of the brain. That is the mechanism, that is the pathophysiology of this condition. Now, if we want to be more specific, okay, and we give you a vignette with the patient that has schizophrenia, and we describe the hallucinations, okay, the autistic behavior, okay, the lack of social interaction, the withdrawal, okay, the delusions. And a question may ask you, which of the following best explains the hallucinations? Well, you have to look for something that says increased dopamine to the limbic system. And if I want to make a multiple choice question about this, for example, I would put 4 options. One says increase dopamine in the limbic system. The other says decrease dopamine in the limbic system. The other says decrease dopamine in the cortex. And the other says increase dopamine in the cortex. Okay, so for the student, okay, who has to prepare for something as difficult as a board examination, as the PANS, for example, it is essential to open in our minds 2 folders. Okay, in one folder, we are going to place everything we need for medical practice, and in the other folder, we are going to place everything we need for multiple choice exams. So at the same time that you are studying disease, you are going to be preparing, okay, for taking examinations about these issues. Okay, so we need to have clear what is what. Okay, what is a disease? What is the mechanism of this disease? Okay, what are the symptoms? What are the signs? Why the patients have this symptom? Why the patient have this sign? Why they may get this complication? Okay, and if we have that clear, okay, we can be extremely successful from the very beginning of the program, as you already have been, but this, of course, needs a little bit more. Okay, so in every lecture, we are going to be using many of these. I recommend you to use them, but let me tell you something. It's not that you study using this, okay? This is, for example, how I would use it. I would study the disease or the diseases in the book or different sources, and then I would come here to see if I have everything clear from what I was reading. And then I would try to create my own diagram or mind map or flow chart or whatever you want to call this. And when I create mine, I would go back to compare. Okay, but I would do this more more simplified. Okay, for example, I would put genetics and dopamine derangement leading to increased dopamine in the limbic system, decreased dopamine in the cortex. The decreased dopamine leads to negative symptoms. The increased dopamine leads to positive symptoms. What are the positive symptoms? This, and this. And the negative ones, this, and this. And that's it. Okay, we don't need to make this so complex or explain that much when we are simply reproducing, okay, what we have in our mind to study. Okay, and you're gonna see how, if you study that way, you are gonna have to study this maybe only once. Okay, and you won't have to be studying the same thing over and over and over and over again. Okay, we have to guarantee long-term retention of the material that we are studying. So let's go back to our syllabus. Okay, you have there all the topics, and please use this as a study guide, okay, for being successful in the program. And the rest in the syllabus is more or less the same, okay? There is nothing new. It's very similar to the one you had during the past semester. Here we have the my plan. This is my plan. This is something that I will try to be, that this gets this way if there is any change in the future. Well, so we are here, okay, introduction, okay, then we are going to be studying briefly the inflammatory process, okay, because how are we going to study dermatitis or allergic reactions if we don't study inflammation first? Okay, we are going to be studying the basics of inflammation. This might take one or sometimes or maybe two encounters. That's why I tell you this is going to be very flexible. That's why I put, okay, so many dermatologic system encounters. Okay, I don't think we need 4, probably only 3, but I want to give some time, okay, so we have flexibility and we are not in a rush. After all the dermatology, we are going to have a review for dermatology, then there is a TBL, and then there is exam. Okay, so it's plenty of time to prepare very well, okay, for the first exam. Now, all of these chapters that you see here, chapter 1, 3, 8, okay, are from the book Pathophysiology of Disease, which is the main book of the course. But in the next section, eye, ear, nose, and throat, okay, there is nothing about ENT pathophysiology in the book, or maybe there is, but it's very spread, okay? So it's better that we use another source that have things more organized, so we don't have to be moving from one chapter to another when we study. So we are going to use the current, okay, the book that you use for, you're going to be using for clinical medicine, current essential of diagnosis, okay, that is also in access medicine, okay, the part 7 for eye and the part 8 for ear, nose, and throat. After this, we are going to have a review and then TBL and exam. Then we are going to move to pulmonology, okay, and 4 encounters, then a review, and then TBL exam, and the same thing for cardio. There are 4 encounters, review, TBL, and exam. Notice that there is a break here, okay? This is in August, because I am gonna be traveling to Spain, something that I had planned from a very long time ago. So there is not gonna be pathophysiology from, okay, August 1 to August 10, so we are gonna continue later. Okay, I think this break is gonna help you a lot because, and I tell you, at the end of this semester, you are gonna need a break, okay? And you're gonna be thankful for that. So, any questions? Any questions about the planning, the syllabus, any recommendation? Oh, well, yeah, that's why I told you this is something that I did by myself when I was me with my mind there. But this is gonna be, there are gonna be changes for sure. Yeah, so probably it's gonna be on the next day, or okay, it's gonna be around that date. Okay, I hear when I created this, I simply was looking at the calendar. I wasn't looking at any other thing. So this is around this date. Maybe it's on the June the 1st, or maybe another day. Okay, the exact dates, I haven't received any information about when exactly they will program this, because this is something that has to be done with the approval of the provost, etc. Okay, so this is simply my planning, but it's very flexible. But thank you for letting me know that. Yeah, that's something that probably is going to happen very frequently when we have encounters of on Mondays, because Mondays, all these days are holidays. Most of them are on Mondays. Okay, so we are ready to move to our first presentation. And we are gonna simply go to start explaining again, okay, what we are gonna be seeing, okay, but more in a more organized way. So this is pathophysiology, and pathophysiology is a very young science, okay? It's a science that started in the last, let's say in the 1870s, 1880s is when the science started, okay, being a science that was started being independent of pathology, okay? Pathology is, let's say, it could be the mother or science of pathophysiology, okay? And this started in Russia and China, okay, when some scientists, some professors of medicine in Russia and China started taking, okay, what they knew, that what they were teaching, okay, about pathology, and started combining this pathology with physiology, okay, making this new science, pathophysiology. There was a lot of controversy about this, okay, because the professors who kept teaching pathology started saying that this wasn't necessary, okay, that in pathology you could cover everything that they were covering in pathophysiology. Okay, I don't know what could be the reason for this disagreement. Okay, maybe it was a problem of money, who knows? Because if you are in a university and there is a department of pathology that is receiving certain budget, and then some professors go out and form a new department of pathophysiology, then the budget has to be divided, no? Maybe that was the reason. And there was a lot of struggle, a lot of debate, controversy. Okay, many professors became enemies because of this division. Okay, but at the end, we have our pathophysiology that started there, and then from Russia and China came to Europe, and from Europe to the United States. And here we are, okay, as a result of all of these things. So let's try to understand, okay, what we are going to be studying. Okay, we are going to be talking about concepts, okay, pathophysiology, okay, the relationship with other sciences, and basically we are going to be covering some terminology that is important to master, okay, and also understanding the importance of pathophysiology, okay, for the medical practice, why we study this, how we use it, okay, to practice medicine. So this is a term that comes from the intersection of pathology, that simply means suffering, the study of suffering or disease, and physiology, okay, that studies nature. Okay, from the word physiology, we have, or it's the same root for the word physics, okay, the study of nature. Now the physics then divided into biological physics and mathematical physics, just to say something different, the physics that we know. Pathology is the study and diagnosis of disease through examination of the organ, tissue, cells, and body fluids. Okay, while physiology studies, okay, as we saw in the past semester, the mechanical, physical, biochemical functions of the living beings. So what we are going to be studying is a mixture of those things, and it's simply trying to understand the abnormalities in the physiologic function of the living beings. Okay, in the past, when people used to study diseases, okay, the diseases were divided into structural and functional. Okay, in fact, we still use the term functional disease, okay, in many cases, but it's simply because we haven't discovered what is the actual disturbance. Okay, for example, let's say someone has irritable bowel syndrome, IBS, which is something that is very common among young people that have some stressful situations, like studying. Being a student is stressful. And maybe the 2-3 days before a high stakes examination, they may have some manifestations of IBS. Okay, some people will have more diarrhea, other people more constipation. Okay, and that can be disturbing sometimes. But if you make a biopsy of the intestines, you don't find anything. Okay, since we don't find anything that explains the diarrhea, we call it functional. Okay, and we still use the term functional for some diseases or disorders like dyspepsia, IBS, okay, and other conditions. But the fact that we don't find anything doesn't mean that there is nothing. Okay, the problem is that we have to develop maybe other ways of detecting abnormalities. Okay, and if we start talking about what we call mental disorders, okay, that is another field that has a lot of controversy. Okay, because for example, let's say you have someone who's having seizures or is having some motor abnormalities, and when they die, you take the brain and you notice that there is a tumor, or you notice that there is a atrophy of the brain. Okay, you have an explanation, but sometimes you don't find anything. But that doesn't mean that there isn't. Okay, so the fact that we don't find something doesn't mean that there is no abnormality. And from that is from where the division between psychiatry and neurology comes from. Okay, neurologists normally take care of the patients that have demonstrated abnormalities in the brain, while psychiatrists take care of people who have signs and symptoms that don't have a structural explanation. Okay, but once we discover what the problem is, then neurologists start treating these patients that were before psychiatric patients. So there is a blurry intersection between what is neurology and what is psychiatry. That is sometimes a little bit of difficulty placing people in one box or the other. So we are going to be studying the disturbances in the mechanical, physical, biochemical functions, okay, that result from disease or any other abnormal condition. Okay, and we are going to be basing everything in determining or trying to understand the etiology. Okay, another word for etiology could be cause. We are going to see how complex this definition is, because sometimes we have to talk about causes. Okay, cause / risk factors. Also another topic of debate. What is a cause? What is a risk factor? Okay, I don't know. I don't remember exactly how many years it took to demonstrate that tobacco smoking is the cause of lung cancer. Not all of the lung cancers, but some specific types. Okay, there was a lot of debate. No, tobacco smoking is a risk factor, not the cause. And even there were researchers that would say, okay, cancer is caused by a genetic disease. Okay, the same genetic disease or mutation that produces lung cancer makes people want to smoke more. That was one of the explanations that was very prevalent those days. And that took a lot of research and struggle, and sometimes really bad things that happen then, to demonstrate that tobacco smoking actually causes cancer. Then we have the pathogenesis. Okay, what links the cause or the risk factor to the clinical manifestation? What is the history of the changes that occur from health or the healthy state to the disease state? Okay, what is the pathway, or what are the pathways? Then we have the clinical manifestations, signs and symptoms, and Based on the knowledge of this, we decide the best therapy or the management. Okay, we are not going to be talking here about treatment, but we are going to be talking here about what is the basis for the treatment, what are the implications, okay, for the management of the patient. And also, when we say management, we are not talking only about drugs. Well, we're not talking only about drugs. We are also talking about diagnostic tests. Wow, talking and writing at the same time. Diagnostic tests. Because when we say, what is the management of that condition? Well, I think the patient has a myocardial infarction, but before giving any treatment, I need to make sure I'm right. Let me do a blood test, let me do an EKG, let me do this, let me do that. And after the diagnostic tests, I'm gonna give some drugs and see what happens. If the patient gets better, I'm probably right with my diagnosis. If the patient doesn't get better, I have to reconsider my diagnosis and treat again. Okay, but in order to develop this clinical reasoning, logical thinking, okay, we need to understand very well what is the pathogenesis that may explain the signs and symptoms, and what is the most likely etiology, so I can treat, okay, or prevent complications, or ideally prevent disease at all. Because the best medicine is the medicine that we use to prevent disease, not the one that we use to treat disease. Okay, and this is something that medical practitioners have been talking about for a very long time, okay, since the times of the first physicians in Greece and before that in Egypt, etc. Okay, health, and it's very difficult to define what is health, okay, because our well-being, okay, is or the definition that we have of well-being is very different for different people, and depend on cultural factors, okay, depends on what your aspirations are, and depends on what is the concept of health and well-being that other people around you have. So it's very, very difficult to say what is health and what is disease, okay, because having someone who is symptom-free doesn't mean that they are healthy. Okay, there are many diseases that take 10 years to manifest. For example, colon cancer. Okay, someone is diagnosed with a colon cancer today and was healthy yesterday. Was healthy. The colon cancer was there. This person didn't know, no one knew. Okay, for the past 10 years, this person was harboring a colon cancer and they didn't know. Okay, so what is the definition of health? What is the definition of disease? Okay, in the ancient times, Egypt, Greece, etc., okay, they used to define health as a balance between the person and the environment. However, environment for the Greeks doesn't mean exactly what environment means for us. For them, this was stars, the planets, the gods. Okay, balance between a person and the environment, depending on what they used to believe. Unity of body and soul, which is practically the same, and harmonious functioning of the organs, and the absence of disease. Now, we don't know when people have disease or not unless we do a screening test. Now, more modern concepts, okay, there are so many definitions of health that would be impossible to cover them all here, okay, but now we talk about maximum capacity of the individual for self-realization and self-fulfillment. And I ask you, what is that? Because maybe I want to be a ballet dancer, but I don't have the capacity. So if I don't get to be a classical ballet dancer, I'm not healthy. Maybe what I have to get rid is of the idea of becoming a ballet dancer. Okay. Health, it will depend on how you define it, and it's the same as happiness, and it's the same as what is being rich. Okay, I remember um, someone came when I started working at Miami-Dade College in the full-time position. Someone came to offer me some plans they have for retirement. Okay, and they asked, okay, what is it what you want to do when you retire? Okay, what is your ideal retirement conditions? What are you dreaming of? And I kept looking at them and I said, I really need a comfortable bed and a very good internet connection. I don't need anything else. Their face changed so much, and this person realized, I'm wasting my time here. Because it depends, okay? Some people have like living in a huge house with this and that and traveling here, traveling there. And if they don't do that, they are not happy. But some people don't need that. Some people just need to be in silence and reading and with good music and good company of friends and family. And that's happiness for them, okay? So that will depend on many things. So for us to talk about health, okay, we need to talk not only about individuals, because if I am healthy, but someone in my family is not, I'm not gonna feel good, okay? And someone that I love is not healthy, I'm not gonna feel good. Even if my dogs are not healthy, I'm not gonna be feeling good. So we have to look at many different factors, but to go to more uh, written definitions, we have to go to the WHO definition. Okay, it's a state of complete physical, mental, and social well-being. And can you tell me who has that? Is there anyone you know that has a complete physical, mental, and social well-being? Okay, I think we are being too demanding here, but this is their definition. Now, in holistic medicine, and we are going to be talking about these things later, health means a relative state in which one can function well physically, mentally, socially, and spiritually to express the full range of one's unique potentialities within the environment in which one lives. I like this more because relative, one can function well, is not a complete physical, because what is that? Okay, so there is no perfect definition of health, but we have to look for our definition and what is the definition that the patient has. Okay, one question that I always ask the patients after they tell me the signs and symptoms, okay, what do you think you have? What have you read about your condition? Okay, how is this affecting your life? Can you work? Can you see your family? Can you eat? Can you go to the bathroom? Can you go do this? Can you do that? And we have an idea of what this condition represents for our individual patient. Because no one is going to have a complete physical, mental, and social well-being, because every day is a different day, and every day there are good things and bad things, and good news and bad news. So now, it's important to understand that this is a dynamic process, changes every day. We feel better today, okay, not so good yesterday, tomorrow we don't know how we're gonna feel, okay? It's a process, okay, that goes from optimum health, okay, and sometimes we lose some capacities, sometimes we have some issues, okay, so we call it better than freedom from sickness. Then we start having some signs, we may see them or not. Okay, let's say someone has a positive antibody, but they don't know. maybe 5 years after this antibody is positive in the blood, but they don't know. They start having some symptoms: stiffness, pain. Okay, the signs tend to appear before the symptoms. Okay, after a time, they may develop a disability and die. Okay, sometimes people may move from this to this without going through the disability. Okay, let's say someone has elevated LDL cholesterol, elevated triglycerides, elevated blood sugar levels, and they may die of a myocardial infarction without going through any kind of disability. Okay, everybody's located somewhere, okay, around this scale. They may move from one to another. Okay, for example, I know a person who is 28-year-old and was having hypertension and high blood sugar levels, and went to see a doctor, and they prescribed a diuretic and they prescribed metformin. And I told him, hey, you are 28. You are taking 2 pills now? How many pills do you think fill in your stomach? Okay, so when you are 60, how many pills are you going to be taking? Lose weight. This guy lost 20% of the body weight, and now it's here. No pills. Now, this doesn't mean that this person is cured. This person has a latent diabetes mellitus and has a latent hypertension. Because if this guy gains the weight again, they are going to move here. Okay? That's important to understand. So we are going to be talking about diseases. Okay? A disease for us will be anything that produces a discomfort in a person. Can be in an area of the body or in the whole body. Okay, sometimes you ask patients and they tell you, I feel horrible. Okay, they can't define anything. I feel sad, I feel horrible, I feel tired, I don't know. Okay, now, an illness, okay, is feelings of pain and discomfort associated to the disease. Okay, let's say someone has a pneumonia, to go back to our patient. That is the disease. Now, the feelings of discomfort is what we call an illness. Sometimes people may be ill without having a defined disease. Okay, when we give a name to the disease or to the condition, we call it disease. Now, the patients look ill or feel ill is different from what disease they have. Sometimes they look ill and we don't know what they have. Sometimes we know why they look ill, because they have some conditions. Now, another thing is sickness. Okay, and that is another topic that refers to the social aspects of ill or health. Okay, there are some conditions that we value as people deserving our help, and some other conditions that we tend to blame the patients for the condition. For example, if someone develops a breast cancer, we all feel very sorry for them. We give them support. We bring them flowers. We try to support their families. But if someone is diagnosed with HIV, we tend to even avoid this person and say, that's your fault. You shouldn't have done this. Okay, or when someone develops, for example, anxiety or depression, we tend to tell them, you need to be strong. Okay, you need to fight, you need to do this, and we tend to say, oh, this person is weak. This person is unable to stand and do what they have to do. When someone develops, for example, obesity, we tend to blame them because of lack of willpower And we tend to tell them, you are eating too much and exercising too little. You're doing bad choices. You have to eat organic food. And we tend to blame the patients for their conditions sometimes. That is what sickness refers to. Okay, or we tell them you are malingering, you are pretending you have a disease so you don't do your duties. Because sometimes a disease relieves people from social responsibilities. They can take time off from work. Okay, and sometimes we believe, oh, this person is not sick really. This person is is pretending they have a condition so they don't do their job. Okay, being sick or healthy has moral and social responsibilities. Okay, and in the past, for example, hospitals tend to, some public hospitals, okay, tend to have there many mentally ill people, because these people couldn't go to the jail. They didn't deserve jail, but they couldn't be outside because maybe they were dangerous, or they were victims of abuse. So to protect them, or to protect other people from them, mentally ill people tend to be in hospitals. But some people who maybe were very poor, they knew, oh my goodness, if I pretend that I'm crazy, I will be admitted into the hospital, and at least I have a bed and food. Okay, so many poor people used to go to the hospitals to pretend they had a mental condition to be admitted and have a life, at least be protected from many dangers and have food and shelter. Okay, and doctors had to do a differential diagnosis to differentiate real mental disease from malingering. Okay, and malingering could put you in jail. Okay, that was a very important job of doctors in the past. Of course, this is a kind of job that I wouldn't do ever, because that is, if you study medicine, is to help people. Doesn't matter what they have. If they need food, they need food. That's part of health. If the doctor or the PA or the nurse practitioner becomes an instrument of the power of the state, that is not the reason why we study medicine, because that would induce suffering, and that makes us like judges, and we are not here to judge people. Okay, that's for people who study to do that. We are not judges. We are simply people who are gonna help others and do not hurt others. Okay, so that is a kind of job that I would never accept. I don't know, but I would try to never accept. Okay, so let's have a break. Any questions before going to the second part? Seven, four, seven. Okay. Okay, perfect. Thank you so much for these things, so I can do the modifications. Are there any questions about this first part? I don't think so. Let's have a 10 minutes break, okay? Let's come back at 11:05 with the rest of the things. Okay, we are back here. And well, let's start talking about what causes disease. As I was telling you before, the debate among scientists, okay, among people who dedicated their life to find what is the cause of suffering and disease, okay, something that goes very, very well back in time. Okay, in the past, many people used to think that disease was something we couldn't avoid, that was like a punishment for bad behavior, and was something maybe related to some, depending on the culture or the country, no? Some people used to think that they didn't pay a favor to the gods, they didn't do the sacrifices in the proper way, or they committed a sin that is hidden and they didn't repent, and different things. For example, here we have a very famous picture, okay, in which you can see a couple, she's pregnant. Notice that she has a previous kid that has a malformation, and the husband is trying to get her away from looking at the ape, because they used to think that looking at apes would bring malformations, okay, congenital malformations. That's just one example. Okay, there were many different myths like this, and I recommend you to once in a while listen to this podcast. That is a great, great, great podcast about the history of medicine, but very, very dynamic. He's an amazing guy, and you're gonna learn a lot about the people who were practicing your profession way before you decided to practice this. Okay, how we have the knowledge that we have now, and what were the different stages in the medical knowledge. Okay, and you're going to be surprised how just not very long time ago, the concepts that we had about health and disease were so different than the ones we have today. Okay, we could go very, very well back in time, but we are not going to do that. And we could be talking here about hundreds of people, but that's not necessary. You're going to be learning with time. Okay, but of course, we have to mention Hippocrates, okay, which is considered the father of medicine. Okay, this guy discovered many things. For example, that uh, diseases have natural causes. And this is something that we know today, but this was not obvious for for many people in the past. Okay, the father of medicine, but also did many contributions to psychology. And remember, it's very blurry the limit between what is psychology, psychiatry, and what is actual disease that is treated uh, by healthcare clinicians. Okay, he discovered that diseases have natural causes that could be investigated and could be treated. Okay, he recommended different treatments that we call holistic today. Okay, we are going to see how this works. And he described some behavioral problems, and his theory about the cause of disease. We have to say it's not something that was his theory. He didn't create the theory of the four humors. Okay, this is a theory that goes well back in time to Babylonian and Egyptians cultures, but he was the one who actually wrote and described and systematically studied the theory of the imbalances of humors. And we are going to see that this is not very away from what the things that we do nowadays. Okay, he criticized, for example, laws that prohibited women from studying medicine in that time. Now, he, for example, discovered that the right side of the brain controls the left side of the body and vice versa. And he described some, for example, symptoms of what we call depression as melancholia, also mania, postpartum depression, phobias, paranoia, and hysteria. Okay, and systematically studied the theory of the four humors. Okay, that we have more about this later. Okay, for these people in the past, every disease was due to an imbalance between what they call the four humors that dominate the body. They call the humors, uh, well, for them the humors were blood, yellow and black bile, and phlegm. Okay, we really don't know what the black bile is, but they used to describe this. Okay, probably the black bile is something that they would observe, for example, when people would have vomiting digested blood that appears black, okay, or when would have a melena, that is a black stools. Who knows what is the black bile for them? And they would use many different treatments depending on which humor they considered to have an imbalance. They would use, for example, bloodletting when there was too much blood. Okay, this was practiced until the 1800s. Okay, so not very long time ago. Nowadays, we use bloodletting. Okay, for example, for people who have hemochromatosis, they have excess iron, and the only treatment is blood donations once in a while. It's the only treatment that I remember that is for that we use bloodletting. He wrote several books. For example, uh, the morbus sacro, which is the sacred disease that epilepsy was considered to be as a result of divine meddling on, and he explained that this could have other causes. Okay, he rejected, okay, different views like these divine provoked diseases, and predicted that these conditions would have physiological causes that would be discovered in the future. Okay, we could say that he was like a prophet of the medicine. Okay, he developed the dry mouth theory. Okay, the theory says that when air passes over the throat, it would dry the throat, and that would create the sensation of thirst to motivate drinking. It's not very far away from the truth. He didn't know that there was angiotensin 2 or antidiuretic, nothing like that. But this is what he discovered back then. So then we have Galen. Galen lived from 130 to 200. Okay, these scientists took from the previous studies, okay, and he combined all this knowledge with the knowledge in the Imperial Library in Rome, and his experiments, his personal observation. He was a physician for gladiators, so he could actually explore the bodies of people, open bodies that in many cases it was prohibited to open a body. And he wrote a lot of books. Okay, the usefulness of parts is one of them. It's describing the body parts. Okay, notice this. He said that everything in our body is important. Okay, he asserted the improbability of creation without divine design. Okay, back then. And then, of course, he didn't know many things that we know today. Okay, for example, bodily warmth. He didn't recognize that the heart was the pump. Okay, but he talked about vital spirit, spiritual substance from the blood. Now, what else? He wrote another book, for example, describing a method for curing diseases of the soul. Okay, he said that diseases arise from passions, anger, fear that could be controlled by understanding and self-knowledge. Okay, this is not very far from the truth or our truth today. Okay, self-love ego blinds us to our own faults without a therapist. Describe the therapeutic relationship and dominated medicine until, notice, the 1600s. Okay, and we are going to see that nowadays we use many of the concepts of Hippocrates and Galen. Now, the humorism is this theory. Okay, these are the four humors. Any imbalance between them would produce different conditions. Okay, and you're going to see later in the resources, I have placed something that it's going to show you the application that this has nowadays in medicine. For example, in the classification and treatment of shock. Okay, some people that have a cardiogenic shock, okay, would look warm and wet. Other people will be warm and dry. Other people will be dry and cold. Other people will be cold and wet. And that has diagnostic and therapeutic implications, as you are going to see later. Okay, the four humors were associated with different moods or temperaments. Okay, for example, people who had excessive blood would said to be sanguineous, very social, very open, extroverts. People who had excess yellow bile or excess phlegm or excess black bile, okay, would have other temperaments. For example, would be cholericus or would be melancholic. Melancholic is what we call depression, excess of black bile. Okay, black is remember melanoma, melanocytes. Okay, so excessive black bile would produce melancholia or melancholy. Okay, phlegm would produce a phlegmatic person, and the yellow bile would produce a choleric, angry person, easily upset person, aggressive. Notice this diagnosis of Galen. I concluded that she was suffering from a melancholy dependent on black bile, or else trouble about something she was unwilling to confess. Now you change the melancholy for depression, and you remove the black bile from there, and everything is like we know it nowadays. So if you want to know more about this, you can take a look at this website. Okay, notice this description. This is a book of medicine that was written in 1495, okay, by a physician, okay, professor of medicine in Vienna. Notice how they are describing the sanguineus, cholericus, phlegmaticus, melancholicus in Latin. Okay, there you have the English translation, but it's not very well, it doesn't have too much definition, but you can see something there. It's the translation of what appears here in Latin, but you have more there. It's very interesting, and I wanted to show you these too. Okay, this is from 1811. Okay, this was published in New York in 1811. Okay, notice that they are giving like a thermometer with different drinks, water, milk and water, small beer, would give you serenity of mind, reputation, long life, and happiness. Then if you drink other things, cider, wine, strong beer, okay, that's gonna give you cheerfulness, strength, okay, and nourishment when taken only in small amounts and at meals. All of this is called temperance. And then intemperance, when you take stronger drinks, okay, gives you vices like illness, sickness, and is punished with death, okay, or gaming, okay, that gives you tremors in the hands and people go to jail, fighting, okay, inflamed eyes, black eyes, and rags as a punishment, lying and swearing, okay, swollen legs, for example, jaundice, okay, the punishment is hospital or a poor house, and so on, and state prison, for example, for perjury. Okay, perjury leads to epilepsy and state prison. And burglary or murder gives you melancholy, madness, despair, apoplexy, which is a stroke, and do for life, gallows. This is extremely interesting how these people, and this is a book of medicine, okay? This is a book of medicine. And this is the explanation that they used to give, for example, and this was published in 1950, not very long time ago, okay? How they associate, for example, dependency during childhood to feelings of inferiority, overcompensation, anxiety, etc., with the development of pride, guilt, need for being fed, with some gastric hypersecretion and peptic ulcer disturbance in the neuroendocrine systems. That is the etiology of peptic ulcer. Of course, they didn't know anything about H. pylori, about different things that we know today. And well, I put this here for you to read. Okay, we are not going to be reading this. This is from 1943. Okay, and it's telling about uh, mental disorders. Okay, in a 23-year-old fighter bomber pilot who had what we call nowadays as conversion a disorder. They would call it hysteria, and they give their point of view about the origin of hysteria and the implications for the patient. Okay, to try to to do therapy on this patient. Neurotic reactions to combat stress. It's like kind of blaming the person for not being strong enough. So going to our topic, these are things for you to read later if you are interested. Well, we're gonna be seeing patients, we are gonna order some diagnostic tests, and we are gonna obtain a result, and we are gonna see if the results are normal or abnormal, in range or out of range. So it is essential for our critical thinking, logical reasoning, to understand how to interpret the results of a test, or how to interpret the findings of a physical examination. Okay, because the concept of normal and abnormal, okay, in medicine, okay, is something that is very relative, okay, and has to be interpreted very cautiously. Okay, the word normal means frequent, typical, usual, average, optimal, adequate, ideal, or expected. But the fact that someone has an abnormal test result doesn't mean that the person actually has a disease. And also, if someone has a normal result, doesn't mean that they don't have a disease. That's why practicing medicine is so difficult. Okay, and you're gonna see that there are many errors that we make. Okay, and these errors may be for different reasons. Sometimes we don't ask the proper questions to the patient, or we don't know how to interpret their answers, or we don't do a good physical examination, or we don't know how to interpret what we find, or we don't order the proper diagnostic test, or we don't know what to do with that. We don't realize what is the link between this finding and these signs and symptoms. Okay, or we don't prescribe the proper medication for that. Okay, there can be many sources of error. Okay, but for us to interpret properly the findings, it's important to know that normal values, okay, will vary according to the age, sex, race, country, and culture. For example, if I do a study about a certain antibody, maybe I go to Germany and I take a population from Germany, Poland, Sweden. Okay, I'm gonna obtain normal values, but these are great for them there. Okay, this range doesn't have to necessarily apply to people maybe in China or in South Africa or in Brazil or in the United States, where we have different types of populations. Okay, that's why it's important to be cautious, okay, about the interpretation. When we say normal, okay, we are taking people who fall between the two standard deviations of a normal distribution curve. That means these values are the average for 95% of the population, okay, of the study that I did. Of course, if we take different studies and we combine them, we are going to obtain better results. But then it's important to obtain ranges for children, young people, older people, black people, white people, Asian people, women, men, etc. And from these studies is from when we obtain what we call epidemiology, which is simply the study of diseases in populations. What determines the diseases? Okay, diseases don't distribute randomly in the population. Diseases appear in people for some reason. Okay, epidemiology comes from these Greek roots: epi, upon, above, upon, demos, which means people, as in the word democracy or demography, and logia, study. Okay, epidemiology is a science that studies the distribution, okay, and determinants, okay, what people get the disease and why, okay, in a population, and it's very useful, the numbers for population studies, but not for individual people. Okay, the fact that someone has a 90% probability of having this disease doesn't mean that they have. Okay, it's a good method for reasoning. Okay, to get, okay, what is the most likely diagnosis? If I have a person who is 20-year-old and is using intravenous drugs and this and that, oh my, this person is likely to have hepatitis C or HIV, but that doesn't mean that they do. Okay, and that's something that clinicians have to self-educate in. Okay, we shouldn't judge people because of certain things they do, and imagine that if they have IV drugs, they have this condition. No, we have to do a test to see if they do, but we shouldn't assume that they have anything. Okay, so in epidemiology, we study populations, but the clinician studies the person, and they need to know, okay, what is this person at risk of? Let me order this and this and this test. And let me do this prevention education. Okay, just if they don't have the disease, they don't get it. Okay, so it's important to understand, and we are going to be talking about some concepts. Okay, the contemporary definition, okay, is the study of distribution and determinants of health-related states or events in specific populations, and how to apply these studies to control the health problems. Okay, nowadays, many people will talk freely about epidemiology and about these topics because of we've been 1 year under a pandemic and everybody's been reading and everybody's very aware. Okay, so this is not difficult nowadays. Public health is the organized effort to prevent disease and promote health. And then we have these topics that belong to epidemiology. What is an endemic condition? Is something that is normally present in a population at a regular rate. Let's say malaria in some countries, or yellow fever, okay, or some other diseases. Now, if they increase there is an increase in cases, or cases appear in other places where they are not normally found, we call that an epidemic. Okay, a pandemic, you don't have to explain. Several countries at the same time or continents. And then we have other concepts, morbidity, mortality. Morbidity is everything that is related or caused by disease or disability. Okay, what is the morbidity due to this, morbidity due to that, and mortality. Okay, how many people die from that disease? Mortality rate of 20%, let's say. Okay, how many people that have hypertension die of a myocardial infarction? How many people with diabetes get blind? Is the morbidity or mortality, how many die of renal failure, let's say. Diseases are considered sporadic when they occur rarely. Sporadic cases of food poisoning in this place. And then we have incidence and prevalence. Okay, incidence refers to the number of new cases of a disease during specific time, okay, in the population, of course, that is at risk. Okay, for example, if you are to study the incidence of a disease, let's say you are studying cervical cancer. Okay, when you study the incidence, you are going to take only women. Okay, you're not going to include men in the population because they are not going to get it. Okay, how many new cases of cervical cancer are per year? Well, this amount per 100,000 people, and we assume they are women. Now, the prevalence is the number of current cases, okay, the new cases, so the incidence plus the one that already existed. Okay, and why are these concepts important? For example, let's talk about AIDS. Okay, before the treatment, existed, when the AIDS epidemics or pandemics started, there was a very high incidence. Many cases per year, and a low prevalence. Why? Because they used to die, so there weren't many cases. Practically, the prevalence was the incidence, because many of them would die almost some months after the diagnosis. Now, after treatment, and with all of the preventive measures like the use of condoms, education, pre-exposure prophylaxis, post-exposure prophylaxis, the incidence has decreased, except for some populations, and the prevalence is high. Okay, because now many of these people who are diagnosed live for many years as a result of the therapy. Okay, that's more or less how these things are important and how this works. Now, going to our pathophysiology, it's important to know what is the cause of a disease. And don't confuse cause with the risk factor. For example, a risk factor is any aspect, personal behavior, lifestyle, environmental exposure, different genetic characteristics in inherited mutations that are associated with diseases. Okay, that some of them can be modified, some of them are not yet. Okay, and this relationship is based on epidemiologic evidence. And for example, some of them are modifiable, some of them are not. If someone inherits a mutation, we cannot change that, not yet. Maybe in the future, with the development of genetics and genetic engineering, etc., maybe we can modify that, but not yet. But some exposures, yes. If you live in a house that is very old and there is lead, you may move to a new house or a different house. Okay, if you smoke, you can stop smoking. If you use excess alcohol, we can decrease that. If you don't exercise, you can start exercising. Okay, and we shouldn't confuse risk factors with precipitating factors. Okay, for example, smoking is a risk factor for everything, but it doesn't, when someone smokes, they don't have a myocardial infarction. Okay, they have to be many years smoking and doing other things probably to have an MI, coronary artery disease. Now, after several years with coronary artery disease, atheroma plaques in the coronaries, because of smoking, diet, exercise, etc., one day they have an emotional upset, bad news, good news. They have a lot of catecholamines, there is a vasoconstriction, the plaque ruptures, and they have an MI. That is a precipitating factor. Okay, there are some examples if you want to go deeper into this difference. And well, what are the determinants of health? There are some social, physical, healthcare, genetic, behavioral, biological. Okay, all of these factors are associated with diseases, but in any case, there has to be a biological determinant to explain the disease. For example, some social determinants, income, education, occupation, class, social support. Okay, if we don't have enough income, we can take care of our health. We can buy organic food or go to a gym or do this or do that, or pay for therapy. Or if we don't have social support, we are going to feel lonely. If we have a job in which we are exposed to noise or to toxins, we are more likely to get a disease. Okay, different factors in the environment, water quality, exposure to toxins, healthcare, what is the access that we have to healthcare, health insurance, what is the quality of the insurance, how are we treated in the hospital, genetics, different mutations that we may inherit or acquire, and behavioral, smoking or eating different things, using alcohol, drugs, etc. Now, all of these behavioral, genetic, healthcare, etc., need to have an effect in our biology and alter the biology of the body, okay, to produce disease. Okay, for example, alteration in the endocrine system, immune system, nervous system, okay, cardiovascular system, as a result of all of these determinants. Okay, so that way we get to the meaning of etiology. Etiology is a science, study of the causes of disease. What is the etiology of this condition? Sometimes there is one, sometimes there are many. For example, HIV is the etiology, okay, of AIDS. But people don't develop AIDS just because of having HIV. They need to have no treatment. They need to have exposure to infectious agents. Infectious, opportunistic infections. If people just have HIV and they have treatment, okay, antiretroviral therapy, they are not likely to develop AIDS, okay, because AIDS is defined as the acquisition of cancers or some opportunistic infections resulting from HIV infection. But if they are not exposed to the organisms and they have the antiretroviral therapy and they have they do it properly, they comply, they're not going to develop AIDS. So the etiology sometimes is a combination of factors. Okay, so and that's what we are going to study. Okay, why of the 1 million people with HIV infection, why only, let's say, 2,000 develop AIDS? Because they weren't taking the therapy, because they were doing this, because they did that, together with having the virus. Okay, so it's important to identify different causal factors that act together to produce a particular disease. Okay, sometimes we don't know anything. Okay, in that case, we call the disease idiopathic. One day we will know. Okay, sometimes diseases result from medical intervention, and in that case, we call it iatrogenic. It's unintended. We shouldn't confuse it with the medical negligence. Okay, this is unwanted, unintended. Okay, many of these are multifactorial. Okay, let's say I'm walking through a very slippery surface and I slip and fall and I have a fracture on my knee or my hip. Why? I had this and the person who was walking by my side didn't. Or because maybe I'm older and I have problems with my equilibrium. But what if they put something that I could hold on? Oh, now is the lack of something to hold myself to, plus the age, plus the balance issues. Maybe I was looking at my cell phone and I wasn't paying attention. So there are many different factors. So it's important to determine the different factors that determine that someone gets a disease. So we try to prevent the disease. And how we know what is the etiology? Well, by doing a process that we call differential diagnosis. Okay, that is simply going from the symptoms to the etiology. You put together the information from the history, the physical exam, lab findings, X-rays, CT scans. When you put all that together, you find the etiology, and then you know what are the different factors, and you intervene depending on your logical approach to the disease. And pathogenesis is simply the process that leads from health to disease, the development or evolution of disease, the mechanisms or pathways, okay, that lead to the manifestations of the disease. Sequence of physiologic events, okay, in response to the etiologic agents. We are going to see that there is a different pathways, okay, which are very dynamic. Sometimes the alteration in one thing will produce alterations in other systems, okay, and these alterations may be studied at the microscopic, biochemical, genetic, cellular, tissue, organ, or systemic level. And the clinical manifestations is what we know as signs and symptoms. Okay, signs, for example, are something that we can measure, we can observe, objectively measured. For example, tenderness. I palpate the abdomen and the patient manifests they have pain. I will describe that as tenderness. Or I will observe their facial expression of pain. There is tenderness. There is fever. I can measure 103. Okay, there is jaundice. Now the symptoms are subjective feelings. For example, pain. Okay, when you do your SOAP notes, subjective, objective, you never write pain here. No. The patient states they have pain, and when I do the physical exam, I observe tenderness. Okay, this can be reported only by the individual. Nausea, for example, is a symptom, but vomiting is something that I see or someone else witnesses. And a combination of signs and symptoms is what we call a syndrome. For example, Cushing is a syndrome that may be due to treatment with the steroids in a person, for example, that has rheumatoid arthritis, or maybe due to a tumor in the pituitary that is producing ACTH. Different etiologies will manifest with a syndrome. And well, when we talk about the stages, about the evolution of a disease, okay, we have to study the diseases in many of their moments when they present. Okay, if I'm sure you have had several different conditions, health conditions, everyone has, or family members, and you observe that it's different at the beginning, in the middle, at the end, and the patients may come to us at any of these stages. Okay, and another question that I always ask the patients, besides what does it mean to you, what do you think you have, is why did you come today? Why today? Oh, because I read that this could be cancer, or because my mom told me to come, or she wouldn't take me on a trip. Okay, the people have many reasons for doing the things they do the way they do, and the clinician has to understand that. So there are different stages. Okay, latent period or incubation period. Okay, for infectious diseases, we're going to see that this latent period is something that varies. Okay, it's the interval between exposure and the first symptoms that appear. Okay, some diseases may have very long latent periods, like HIV infection may have or AIDS may have a latent period of several years. Okay, syphilis may have several latent periods. That's why we have primary syphilis. Primary syphilis, then they have the lesions on the genitalia, then they have no symptoms. These lesions in the genitalia disappear, and then they have the secondary syphilis. They have maculopapular rash everywhere, and then they have the tertiary syphilis, which is the central nervous system affected. This is a latent period 1 and latent period 2. Okay, so every disease will manifest differently. Sometimes the latent period may occur after what we call the prodromal period. Okay, what is the prodromal period? The first signs and symptoms. But these are unspecific, vague. And we know when we are going to have the flu, for example. Oh, I'm feeling terrible today. I don't feel I'm myself. I feel weak. I have these muscle aches and joint pain. Okay, I'm incubating something. No, you were incubating. Now you are in the prodromal period. Okay, in some cases, for example, if we irradiate the body to perform a bone marrow transplant, okay, they are going to feel really bad, prodromal, and then they are going to have the latent period until the actual symptoms appear. Body radiation may be as a result of being exposed to a nuclear accident, Chernobyl, or any atomic bomb. Okay, when they are exposed to radiation because of a nuclear plant accident, they're going to have burns all over the body. They're going to feel terrible. Then they get better, latent period, and then they develop cancers, leukemias, thyroid cancer, different things. So diseases are classified as acute, chronic. This is something that is not new. Okay, acute conditions last for a short time, hours, days, few weeks, months. Some people die. Some people survive. And they are free of disease. But in some cases, the diseases may prolong, and we call them chronic. Okay, for different diseases, the time is different, but generally is more than 6 months. There's a word missing there. Months to some years. Normally, chronic diseases are not curable. That's why we call them chronic. Okay, in some cases, diseases may have exacerbations and remissions, exacerbations and remissions, exacerbations and remissions. So they get worse and now they feel better, worse, better. Sometimes the remission may be permanent. When there is a remission for more than 5 years, we say the person is cured. We say, we don't know what's going to happen. There are some other periods, for example, convalescence. Okay, this is the recovery after a disease. Sometimes they have some mild symptoms that get better. For example, if someone has some neurological problems, they may start getting better over time with physical therapy, medications, etc. Sometimes diseases produce sequelae, which are permanent pathologic conditions, paralysis or blindness, etc. Scarring may be the sequela of an inflammatory process or a wound on the skin. Deformation, scarring of the cardiac valves as a result of rheumatic fever. And some diseases have complications. Complications, it's important to have clear the difference between complications, sequelae. Okay, a complication is something that is a new or separate process. For example, someone has a bacterial pneumonia. A bacterial pneumonia may be a complication of a viral infection. That's something that has nothing to do with the other disease. As a result of a viral infection, okay, people may develop some, normally there are not sequelae as a result of viral infections. But for example, if someone has a bacterial pneumonia as the primary disease, a sequela may be a destruction of part of the lung tissue. But a complication could be heart failure resulting from a very severe pneumonia or sepsis, septicemia. Let's see a couple of examples. Here we have the infectious period, for example, the different stages of COVID-19, talking about the infectious period. People are exposed one day. Okay, notice that the incubation period may last up to 14 days. Okay, but the infectious period, okay, has to be defined depending on the findings of the clinical cases. Okay, the time that the patients shed viruses, 48 hours before the start of symptoms, is the infectious period. After this incubation period, they start having a symptomatic period, okay, in which the symptoms get worse and then go down, period of illness. Then they start having a recovery and the symptoms end. But notice that 72 hours, okay, after the person is symptom-free is when we consider the patient out of the infectious period. Okay, so for every disease, this is going to be totally different. Okay, but we are studying here some general definitions. Let's see what we studied before with the example of hepatitis A. You have the incubation period. Notice that during the incubation period, okay, we don't detect antibodies. Okay, antibodies start being detected in the prodromal period. In the case of hepatitis A, that is not for every disease. In the case of other conditions, you may detect antibodies before. This is just one example. Okay, there are no antibodies, but you can detect the virus in the blood by looking at the RNA. Okay, it's important to determine, the knowledge of this is essential to determine what is the best test. Okay, for every patient at any moment. Let's say you have a patient who tells you, listen, my wife, my mom, my kid, they got diagnosed with hepatitis A, and we've been at home these days, and we've been sharing some different things at home. So I want to know if I have the hepatitis A. Do you have any symptom? No. Do you? Nothing. Everything is fine. So if we look for antibodies, they are going to be negative. In that case, we have to do an RNA test. Okay, if they are here, that's not likely to appear. But it's the best test at the very beginning when the patients don't have any symptom. Now, when they start having the prodromal symptoms, start feeling bad, nausea, anorexia, is when you can detect some antibodies, for example, IgM antibodies. Then when they develop jaundice, then you can detect other types of antibodies. And then they have the convalescence period. Notice how some antibodies decline and some other antibodies stay for a longer time, because this tells you that the patient is immune, already had the condition and is immune. IgM is the antibody that appears in acute diseases, and IgG appears in chronic diseases and indicates that the body is protecting or not against the disease. For example, IgG antibodies in a person with HIV, we know that the antibodies are there, but these antibodies are not protecting the person. And well, pathophysiology has a lot of implications for treatment, as I told you before, okay? Because an understanding of all of this process for every disease, okay, is going to help us to decide what is the best treatment for the patient. Okay, what's the pathogenesis may indicate what is the best therapy. A patient may come because of a shock or hypotension. Hypotension may be due to, for example, septic shock or cardiogenic shock. Patient has an infection, has a myocardial infarction. If someone has hypotension because of sepsis, okay, the mechanism linking sepsis with hypotension is excessive vasodilation. Okay, but the patient with cardiogenic shock, okay, this occurs because the heart is not pumping properly and the fluid is accumulating in the lungs, so there is a fluid overload. So in the first case, in the case of septic shock, maybe fluid administration will be helpful, plus the antibiotics, of course. But if the patient is in shock because of fluid overload, we are not going to give them fluids. That will worsen the condition. We have to improve the cardiac function, giving diuretics to remove the fluid. That's the importance of knowing very well what is the pathogenesis. Okay, the pathophysiology is going to be very useful for making general statements as about the treatment, but of course not for telling you what is the exact medication that the patient needs, because that is more for clinical medicine and pharmacology and something that is determined by depending on the individual factors of that specific patient. And well, I think we are gonna stop here. Okay, we are gonna stop here. We are gonna continue with the rest on Wednesday. Okay, that we are gonna be talking about other things. I don't want, we just have very few minutes and I don't want to rush over anything. And I just also want to stop to ask you if you have any questions. Okay. Well, if you have any questions later, just write me, okay, anything. And we continue on Wednesday. Stay safe, take care, and enjoy the rest of the day. Wednesday is from 5 to 7, okay? We'll see you then. Bye-bye.